Does anybody have any questions right now, or anything you want to ask me?
Well, that one, there was someone in the corner raised a hand earlier. Did you have a question? Did it get answered?
Question for you, doctor. You said earlier that the hepatitis C virus replicates at about 1 trillion copies per day. So how can somebody have a viral load less than 1 trillion at any time?
Yeah, it's interesting. You clear 1 trillion copies a day too. So you keep a steady state. So what happens is, regardless of when you have, like, if you do your viral load multiple times, it might stay 1,800,000, 1.2 million, stuff like that. You get that fluctuation. But what's happening is you actually have 1 trillion copies coming in and 1 trillion copies going out. And it's probably getting destroyed by your immune system, by your reticuloendothelial system. You know, the way hepatitis C was diagnosed is by what? Antibody test. So your immune system is reacting against the virus. It is trying to clear it. It just can't clear it completely. And so there's a T cell response and a B cell response and all this happening, but they're just they're not completely ineffectual. And your body does have mechanisms to get rid of this virus that's replicating at such a high rate.
Thank you very much.
I have a question because you touched on it. You touched on this whole how we are at a higher risk for liver cancer.
Yeah.
I'm one of the lucky ones. I've been cured clear for 8 years.
Mm-hmm.
Should I be getting some kind of scan? I do have a friend who died of liver
Yeah,
cancer
yeah.
after having hep C. I was in interferon-based genotype 3.
Yeah. Do you have cirrhosis? Did you have cirrhosis?
Yeah. I mean, I was in stage 1.
Yeah. Okay. So the recommendation is, if you do not have cirrhosis and you clear hep C, you probably do not need surveillance screening thereafter in terms of ultrasound. It's basically the patients with cirrhosis who clear hep C. Now, okay, that's a recommendation.
Right.
Now, if you're asking me, Dr. Everson, what would you do?
My deductible is the year. So
Right.
I'm asking this question.
I have had patients, even with lower stages of fibrosis, end up with liver cancer. So I'm not, and it certainly can happen. It happens at a very low rate. For stage 1 fibrosis, you're probably down to population risk. So we don't screen the whole population. So generally for you at stage 1, I probably would not recommend any screening. If you had stage 3, like not cirrhosis, but stage 3, I would. And I would screen you like you had cirrhosis, meaning at least once a year, as frequently as every 6 months, but at least once a year, an ultrasound is what's recommended. There is another test, a blood test called alpha-fetoprotein. It's not actually even in the recommendations anymore from the liver societies, but patients who I follow, they'll see that I do track alpha-fetoprotein, because if I do see that alpha-fetoprotein rise up and your ultrasound isn't showing anything, I may reflex to a CAT scan or MRI. So I do use alpha-fetoprotein as a modifier, but that's not a standard recommendation of the societies these days. So surveillance of a patient with cirrhosis is typically ultrasound of the liver at least annually, and we don't know how long that goes on. We don't know if the at-risk period is 10 years, 20 years, or for the lifetime of the patient. So this can get pretty expensive if you clear when you're age 30 and have cirrhosis. So we're trying to develop tests that can assess what the risk is for future cancer. We're not there yet, but there's some promising things. So hopefully we'll be able to manage that a little bit better in the future. I think, yeah, go ahead.
Hi, yeah.
By the way, this is very informal. You know, this kind of forum, there's no such thing as a dumb question or stupid question or anything like that. And if you have something you want to ask about anything related to hep C or, you know, natural history or liver or whatever, just this is the time.
Yeah, can you explain the alcohol and hep C connection and why insurance companies are looking at alcohol use and hep C?
It really is problem drinking, not so much just alcohol per se. The trouble with alcoholism is that it isn't there may be a direct effect of excessive alcohol intake on response to some of these antiviral drugs, because when you drink a lot of alcohol, it changes your liver enzymes. And what organ metabolizes all these drugs? Liver. So it's very important, to stay off alcohol during the time you're on treatment. Now, an occasional glass of wine or something is okay, but daily drinking to excess is really could harm your ability to respond to these medicines. And after all, Jacob said you're spending $95,000 for 12 weeks, so stay off the booze there. I think the most important thing is that alcohol is a liver toxin, damages the liver and leads to cirrhosis. Hep C damages the liver. It's a different toxin, a biological toxin that leads to, yeah. So you got two things going on there. You can deal with one without even treating the Hep C, right? So that's really the message. Now getting back to the costs in Europe, the costs, worldwide, the money paid for this treatment is highly variable. I mean, in Pakistan, I heard it was like $6,000 for a 12-week course or something like that.
Yeah, I was gonna say.
How much? For 12 weeks?
I think it's 900 for 12, and then for 24, it's 1,800 bucks.
So there you go. Get a flight to Cairo. Yeah, Well, maybe the insurers will do that. Maybe
And a hotel.
yeah. Be sure it's safe, though.
Yeah.
Well, Europe, we're talking first world countries, Europe, Belgium.
Yeah, and-
Places like that negotiate with pharmaceutical
Yeah.
companies for their health.
Yeah. Same with France. Yeah, France hasn't.
It's gotta be lower, right?
Oh, it's much lower in Europe. Yep.
Way lower.
Yeah. I don't know what is the price in France? Do you know for a course?
I'm not positive. I read a really interesting article about a week ago that was discussing, and what the French government did. They have single payer health care from the government, and so instead of they were attempting to negotiate with drug companies. I think they got a little fed up, and what they ended up doing was they actually put certain drug companies in a different tax bracket, and said that if your total costs to our system exceed X amount of euros, and I don't remember exactly what that number was, we'll just tax you more and get it back. And so it's interesting. And in Scotland,
Jacob's on the hit list now from.
seriously, it's, when Dr. Everson does a talk, he has a long list of people who've supported him in his years. When I give a talk, I say no disclosures. So maybe someday. But when another thing in Scotland is they're actually in negotiations right now. What they're doing is they're actually doing a pay-for-performance type thing, where if the Hep C medication doesn't work, they will get refunded the money by the manufacturer. And so it's interesting is that different countries, different insurance, different things are kind of finding different solutions. And I think that what we're talking about today will be different than how we're talking about it in 5 years. And it'll be interesting to see how that develops. There's a question in the back.
Yeah, I have a question for both of you.
Yeah.
Jacob, I assume there's a Gilead has patient assistance program,
Yep.
and I was wondering if you could just comment on how generous or stingy it is and how difficult it is.
Yeah, I definitely can. So we've used, it's called My Support Path. It is a private, quote-unquote, healthcare foundation, but it's fully supported by Gilead. So they're the ones who make sofosbuvir, and they're the ones who also make sofosbuvir, ledipasvir, or Harvoni. So they have drugs on the market right now. So far, it's been fairly generous. What they do is that they take people who have insurance but have been denied by the insurance. If we have 2 denials, so we've appealed and the appeal has been denied, then they've stepped in and covered it, and they currently don't have a financial limit on the patient, so it doesn't matter what the patient makes. And so we've gotten, in our clinic, I would say about 15 to 20 patients on treatment through that program, which has been really positive.
What's it called?
It's called My Support Path.
But that's only for people with insurance.
Yep,
What about?
exactly.
Do you have any of the drug companies who are working with Medicaid patients?
So Medicaid is different. So Medicaid is that most of our patients with, so Medicaid is a state-run organization, so every state is different. In the state of Colorado, if you're denied by Medicaid, My Support Path is still available. So you could be Medicaid and access that. If you're Medicare, you're going to have higher drug costs. We have other programs that are healthcare foundations that sometimes will step in and help with copays. So we have kind of a team approach here, and we also have a person in the pharmacy who does a fantastic job of helping link patients if it comes back with a high copay or kind of comes back with denial, of kind of seeing what other options are available.
My question, I have two questions.
Oh, yep.
For the doctor. So in those studies, I know that the percentages of non-responders were very low, but did they try to tease out if there's a commonality among that? What did they do for adherence measurement? I would assume these people would be very adherent, but that's the number one thing to look at.
Yeah.
Is there any other reason why? I mean, those people still did fail.
Yeah. A lot of this is being kind of looked at, that's what they're pouring through every possible predictor, host response, viral characteristic, immune responses. Nothing seems to be there. That's.
You know what they did for adherence measurement?
Well, that I think is probably the Achilles heel, because no matter how simple a regimen is, humans are humans, and there's always some non-compliance. I mean, when this has been studied, even with the simplest regimens, there is a non-compliance. Now you'd think, well, my goodness, one pill a day for 12 weeks, you'd think anyone could do that. Well, you'd be surprised. Doses do get missed. And the other thing I think, I look at it, there's two characteristics of human beings, I think, that come into play on this. One I just mentioned, which is we forget. It's not, it's just we forget things. We have busy lives, and you get up one day and the kids are screaming, and you got to go to work, and you get back and dinner and blah blah blah. Next thing you know, oh my God, I forgot my medicine yesterday. I mean, that's probably happened to everyone in the room to some extent. So I think there's just this natural stress factor of living in a complicated life and forgetting things once in a while. So I think there is some misses. But there's another part of human nature. We don't want to admit that we miss. And especially in a study where if you miss doses, that's a big deal in a study, right? I mean, the coordinators are, you get an evil look from the coordinators. Like, you're a lesser being or something. So I think there's a natural tendency to kind of not admit it that you've missed a dose. So I think there's a guilt factor that comes with that. So I think there's under-reporting of missed doses. And so getting back to your question, we look at adherence two ways. One is, of course, just by the pill counts and stuff like that. But for the situation where we realize that people are humans, we go back and look at these cases to see if there were times when the drug level was 0. And there have been a few cases where that has been true, consistent with someone who was not taking their medicine. But most of the time in the trials, there's no evidence of missed doses based on drug levels.
Yeah, I was just wondering if, a patient, or not a patient, but someone with Hep C takes milk thistle, is that okay to continue taking that when you're on treatment? And also I'm wondering...
No.
Oh, okay.
Don't mess up this treatment. You get one shot with this treatment.
Okay.
The insurers are saying, and you get one chance. So you don't want to do anything that could possibly compromise. We can't study every drug interaction because there's 50 million over-the-counter products. So if someone's prescribing you this medicine, don't mess it up by taking anything else over the counter.
And I just wondered, is
Do you agree with that?
So in our approach in clinic, and I definitely stand behind this, we get a lot of questions. I get a lot of questions personally about herbal supplements, is that herbal supplements don't have to be tested to prove efficacy or safety, but especially not in patients with any type of liver disease. we know most things are metabolized through the liver, and patients in our clinic have hepatitis C. They have liver issues, and so these have never been tested. And so especially on treatment, we say is that take away all variables.
Next part to your question, part B.
Oh, I was just wondering, is coffee good or bad for your liver?
I love coffee. Make sure it's good coffee.
Yeah.
But it turns out that if anything, coffee seems to be a liver loving entity. There's no problem with coffee in the liver.
I wanted to hear what he says.
So coffee is it's been actually studied. We did a study here. It was a real big study. We did with the NIH, and we enrolled something like 220 patients in this one center into this study at the NIH, and there's something like 75 papers came out of this study. Basically, every aspect of hepatitis C came out of that study. One of them was your question, because prior to having prospective data, there was all this, stuff in the natural healing world that you should avoid coffee if you have liver disease and so on and so forth. And it turns out that when we looked at coffee as a variable in terms of the severity of liver disease, not only that, the progression in liver disease, the response to antiviral therapy, the chance to have varices, all the complications of liver disease, if anything, it was protective, not detrimental.
But
So
isn't
there-
that illogical?
What's that?
Isn't that illogical? On the one hand, you're saying you can't take supplements because they're metabolized in the liver, so it could mess up your treatment. But coffee, because it's popular and it's nice, gives you a high. Well, that's okay.
Well, you don't have to take coffee. I'm not telling you have to. I'm just saying it's the one
It's
supplement.
okay to take
but it-
caffeine, but
but it's-
not the supplements.
No, but it's the one supplement, natural food, that's actually been investigated extensively. So that's all I'm saying.
Okay, thank you.
But you don't have to take coffee. I'm just saying it's not a therapy. Don't get me wrong.
This has been around for thousands of years,
Yeah.
and there's no evidence that it causes any problems.
There you go. I'm with you. So do you like coffee? Are you a coffee drinker?
I don't like to take caffeine. Anything that I'm addicted to, I avoid.
That's good. Okay.